Okay, so the next section we'll talk about is endocrine drugs. And again, we're talking about very, very few categories of drugs for this. There are a lot more, but drugs that deal with thyroid disease. Thyroid disease can either be hypo or hypothyroid. It can have several different causes. Hyperthyroid, the negative loop mechanism gets turned off. So the thyroid continues to produce thyroid hormone inappropriately. So that requires some kind of anti-thyroid medication. And typically that's going to be medication that or treatment that either partially or completely destroys the thyroid gland to stop its overproduction. So if the thyroid gland is not functioning, then that patient will have to take thyroid replacement hormone. For hypothyroid, the treatment is thyroid replacement hormone. One thing is that anti-thyroid medications and treatments tend to have some risk for other tissues. And also, if the patient is pregnant, there's risk to the fetus. And so they're chosen based on the time during pregnancy. For diabetes, we have two different categories, but we have oral diabetics or anti-diabetics, and then we have insulin. Oral anti-diabetics, though, have multiple classes. They're broken down into how they act. So there are several different classes of meds that increase insulin production. One example of that is sulfonylureas. So sulfonylureas increase insulin production. There are drugs that decrease insulin resistance, like metformin. There are drugs that promote glucose elimination. Some of the newer drugs actually cause more glucose to go into the urine, which takes more water with it. And there are drugs that block carbohydrate absorption, like acarbose. So I want you to think through what the potential risk and side effects could be with those classes based on their mechanism of action. So patients on a sulfonylurea, they're at risk for hypoglycemia if they take their meds and don't eat. Metformin has a lot lower risk of hypoglycemia because it doesn't work by increasing insulin. It actually decreases insulin resistance. Metformin also decreases the breakdown of complex carbs and sugar absorption in the gut. And so it leaves more carbs and sugar in the gut to ferment. So it is associated with some GI distress for some patients. If a drug promotes glucose elimination through the kidneys, then we're going to have polyuria. So that patient may have difficulty maintaining hydration. But also, if they have glucose in their urine, that's going to increase the risk of infections, both yeast infections and bacterial infections in that region. And then if a drug blocks carbohydrate absorption, it's likely to result in diarrhea and GI distress, because carbohydrate that's not absorbed from the gut sits and ferments before as it becomes stool. So that creates some GI distress. Insulins are classified by peak onset and duration of action. And if you look in your drug book or in your pharmacology book, you can find a chart. We have immediate acting, we have rapid acting, short acting, intermediate, and long acting. So a rapid acting insulin is something like Lispro. Those work within 5 to 15 minutes. Their onset is 5 to 15 minutes. They peak very quickly, usually in an hour, and they're eliminated very quickly. Short acting insulin is regular insulin. It onsets in maybe 30 minutes. It peaks in a couple hours, and it lasts only a few hours. Intermediate is like NPH insulin. It doesn't even onset for a couple hours. So if you take NPH insulin at breakfast time, you're not covering the breakfast meal. It's going to peak around lunchtime or a little later. And then it lasts usually around 12-ish hours. And you can look at the specific numbers, but NPH is usually dosed twice a day. The long-acting insulins last 24 hours and they don't really have a peak, but they have a very slow onset. So again, if someone takes their Lantus at 7 a.m. and then eats breakfast, they're not covering breakfast at all. That's a maintenance dose. So they may also need a rapid or short-acting insulin to cover those meals. Okay, reproductive system is the last one we're going to talk about in the endocrine system. And I told you we're only doing these three. There are more endocrine organs and all of them have medications that address specific issues. So we're only doing these three for the purpose of this test. So the reproductive system, we're going to talk about hormonal contraceptives. There are multiple different methods of contraception, but a lot of those methods involve hormones. So there are combined estrogen and progestin contraceptives. They combine estrogen and progestins. They're monophasic that maintain the same level of both throughout. They're biphasic that change the levels. There's two different hormone levels, and they're triphasic that have actually three different changes throughout the cycle. I don't want you to get caught up on what those specifically are. If you're interested in that, Ms. Durant gets into it in her pharmacology class. But when we talk about monophasic, biphasic, triphasic, that's what we mean. It's how many different combinations of hormones there are. Traditional birth control pills had 3 weeks of active hormone, and the last week of pills was placebo just to help patients stay in the habit of taking that pill every day so that they would not forget to restart the next pack. Now, it's been learned that it's not necessary for health to actually have bleeding every month. And so there are extended cycle and continuous use oral contraceptives that just continually keep the hormones, keep ovulation suppressed and bleeding suppressed. Well, hormonal contraceptives work by suppressing ovulation. They also make the cervical mucus hostile to sperm. Some people think that they could potentially prevent implantation, but that's thought to be pretty unlikely. So, and that matters to some people from a moral or ethical perspective. It's pretty unlikely that combined oral contraceptives are preventing implantation. Well, they work by suppressing ovulation. They fail when people miss them or if they're taking a medication that affects absorption because they fail to suppress ovulation. They also tend to make the cervical mucus hostile to sperm. If it's thick and sticky, the sperm gets stuck and they can't get to the ovum anyway. Progestin-only pills contain progestins only. There are a couple of benefits to them. Estrogen-containing meds or containing oral contraceptives can actually increase the risk or increase the growth of some cancers. So if a patient has or is at risk for a type of cancer that is estrogen dependent or that estrogen tends to increase, they would be recommended not to take estrogen-containing contraceptives. And combined oral contraceptives can suppress lactation. So if a patient has just had a baby, wants to breastfeed, then progestin only is much less likely to suppress lactation. So progestin only is also an option. They work by suppressing ovulation. They are less effective than combined oral contraceptives. And the window of missed pill is much more narrow. They really, all oral contraceptives should be taken the same day for the greatest effectiveness. Progestin only, that's even more critical because If they miss even by a few hours, they can actually ovulate. Also, they tend to make the cervical mucus hostile to sperm. There are alternative routes to administer hormones. There are implants that administer a steady level of hormones over a period of years. There are IUDs. IUDs are intrauterine devices. One type of IUD actually contains hormones that are gradually released. There's the Nuva ring, which is a ring that's a vaginal ring that's placed every week for 3 weeks and then a week off. There are injectable hormones that suppress ovulation. There are patches. So there are a lot of different ways to administer. And again, if you want to get deeper into how each of those work and what the pros and cons of all those methods are, Mr. Rant's pharmacology class, the pharm 2 includes, pharm 1 includes a lot of information about oral contraceptives and different contraceptives. One last thing I want to talk about with contraceptives is emergency contraception. And that's mostly because I want to clear up a misconception. A lot of people believe that emergency contraception is the same as abortion because it prevents implantation. Emergency contraception actually doesn't typically prevent implantation. They've studied this and they don't see a lot of evidence that it prevents implantation. What it does is delay ovulation. Emergency contraception consists of larger doses of hormone than just an oral contraceptive. There are providers who will give instructions to patients who are already on oral contraceptives for how many pills to take to actually do this without having to go out and buy a Plan B packet, because it's essentially the same thing. So it's a larger dose of the same hormones that are in combined oral contraceptives, and the closer to the incident they're given, the more effective they are, because the goal is to suppress ovulation. So in order to understand that, you need to understand, we'll get into this a bit in the next lecture, but you need to understand a little bit about conception. Sperm can survive in the reproductive tract for up to 5 days. There are some outliers that may survive 7 days, but up to around 5 days. The ovum, once it's released, can be fertilized for about 24 hours. After about 24 hours, it's probably not going to be successfully fertilized. So if someone has intercourse or is sexually assaulted, if there's sperm present in the reproductive tract and ovulation has occurred in the last 24 hours, their chance of pregnancy is fairly high, and an emergency contraceptive is not going to change that. Okay, it doesn't affect the uterine lining, and it won't affect that because the ovulation's already occurred. That's why there's about a 15% failure rate with EC. If though they are near ovulation but have not ovulated yet, EC can delay that ovulation until after that sperm has all had time to die. So if we can delay ovulation by a week, that patient is very unlikely to get pregnant. So you need to know that for 2 reasons. Number one, people are sometimes afraid that it's causing an abortion. So we can explain to them that actually intercourse and fertilization can be several days apart. And so that gives some time to prevent ovulation, to prevent that fertilization. But also, if we suppress ovulation for about a week, that patient next ovulation may be at a time they don't expect it. So they could actually get pregnant again, or get pregnant in a week or so, because they ovulated again, or didn't ovulate again. They ovulated. They were supposed to ovulate say on the 1st of a month, and they took emergency contraception, that delays ovulation. They might ovulate on the 7th of that month, and they're not expecting to ovulate at that time. So if they have unprotected intercourse, they could actually get pregnant at that time. So they need to know to take or to use some barrier method of contraception for a few weeks until they've had a normal cycle afterward. That is different from a medical abortion or abortifacient medications. Medical abortion causes the disruption of an implanted pregnancy. If an egg is fertilized and it's not implanted yet, they're not likely to affect that. But it causes the disruption of an implanted pregnancy. There are some different options. The majority of them are going to be something to stop cell division, or something to cause uterine contractions, so that it causes a miscarriage. So you need to understand the difference between those things, because the public mixes those up a lot. Okay, the very last section, we will talk about pain management and psych meds.